going to not stress too much on certain things. Many of it is there in the text. I'm just and the second part is going to be on a dilated biliary tree or a dilated biliary system. I'm going to not stress too much on certain things. Many of it is there in the text. I'm just going to tell you all some key points, some take-home messages for each of these. So let's start with the first lecture for the day, that is on cross-sectional imaging in focal hepatic lesions. Again, like I said, I'm not going to talk on extrahepatic or secondary disease. I'm primarily going to talk on primary focal hepatic lesions, and this is generally the entire spectrum or gamut of focal hepatic lesions you see in the on imaging. And you will have the important thing to take home from here is that you first look at whether the liver parenchyma is normal or you have an abnormal liver background parenchyma, and based on that you characterize your spectrum of lesions. I've not put the entire gamut. I'm not going to talk on metastasis at this point of time. I'm not going to talk on cholangiocarcinoma. That's for the second half of the lecture. So our primary interest, whether when a patient comes to you on cross-sectional imaging, is what kind of lesion are you looking at? Is it focal? Is it diffuse? If it's focal, is it cystic or is it solid? And that's what your sonologist comes in and tells you straight away, that you have a focal cystic lesion or you have a solid cystic or a solid lesion. So let's take it that your sonologist has done a scan, you have focal cystic lesions. So this is the entire spectrum of lesions you have for focal, solitary or multiple cystic lesions in the liver parenchyma. Again, if you see the entire spectrum, it's huge. The numbers are and you can get cystic metastasis, cystic cholangiocarcinoma, you can get cystic HCCs, whatnot. So every solid tumor can have a cystic counterpart as well. But what I'm going to do is I'm going to try to focus on certain specific entities which are going to be clinically very viable and very important for you all. And out of those, whatever is highlighted in blue is what I'm going to try to speak to you about. Again, developmental hepatic cyst, the commonest of the lot. Caroli's disease has a direct extension of those. And then, of course, you have biliary cystadenomas, your infective pathologies, and some complicated cysts. This is what it comes to you as when a sonologist sends it to you, that he will tell you that you have a focal cystic lesion with or without a solid component, without septations or calcification, and you need to evaluate this, whether this is benign, this is questionable, where you need to aspirate or put in a needle, or you just leave it as it is. So what do we look for in CT and MR? So these are the predominant findings which should be accompanied with a cystic lesion of the liver. So A, is it solitary or is it multiple? What is the density or the intensity of the lesion? What is the nature of the walls, the septae? Is there calcification, which is of course better seen on CT rather than MR? Is there a solid component? Is there intracystic hemorrhage? Is there intracystic fluid levels? And of course, look at what's happening to the adjacent liver parenchyma. Look at the periportal space, intrahepatic and extrahepatic. So what exactly is a hepatic cyst? It's a developmental cyst. A true hepatic cyst is something which is developing along the periportal space and does not have a wall. It's an imperceptible wall. Once you see an enhancing wall, it is not a true developmental cyst, but an acquired cyst which occurs following obstruction to the ostium of the peribiliary glands. So typically a cyst is something which is fluid density, fluid intensity, hypoechoic, without septations, wall thickening or mural nodules, without a perceptible wall. Once you get a perceptible wall, it becomes actually an acquired cyst or a simple hepatic cyst. Generally per se, they are of no worry to you. Occasionally, a patient with a simple hepatic cyst may come with an acute abdomen. Why? Most likely, it's because of intracystic hemorrhage. Like this one out here. You have a large cyst without much enhancement of the wall, but you actually see a debris, rapid expansion of the cyst. And of course, if you look carefully, there is biliopathy. So a simple hepatic cyst which can